committee meeting for January. Right, to remind everybody, when you talk, could you please introduce yourself so that we know who's speaking? And to begin, could we have a roll call? Marcin.
Sure. Grant Ritter.
Here.
Peter Dolittle.
Here.
Mark Schaefer. Matthew Brockman.
Here.
Manisha Jutani.
Here.
Thank you. Toon Goin.
Here.
Neil Kelsey.
Here.
Alan Skinner. Jill Zorn. And Paul Lombardo.
Here.
Thank you. We do have a quorum.
Okay, great. Okay. There is no public speaking this meeting, so let's next turn to Susan to introduce a new member.
Thank you very much, Grant, and welcome everybody. So I just wanted to start today to introduce a new member of the committee, who is Commissioner Manisha Jutani, who is the Commissioner of the Connecticut Department of Public Health. She's also an ex officio member of our board. And her background is very important, I think, for this committee. She is an infectious diseases physician who previously worked at the Yale School of Medicine and led the ID efforts at the Yale School of Medicine and Yale New Haven Hospital during the COVID-19 pandemic. So we welcome her and are very excited to have her input for this committee. And then also, I just wanted to take a moment, Grant, and just introduce a new staff member in the Plan Management Department, who unfortunately is a little under the weather today, but I believe she's on listening. Kelly Cody has joined the team as a carrier product manager last spring. And just to remind everybody, Ann Lopes and Alan Kelleher did retire in 2021. So yes, we're very sad to see them go, but wish them well in enjoying their retirement.
In Florida.
Yeah, no, they're still in Connecticut. And just to welcome Kelly and to let everyone know that Kelly, we're very fortunate to have her join our team. She comes to Access Health after a long career at Aetna as an underwriter and a project manager. So we're very excited to have her as part of this group. And then just to touch on for the next item, Grant, the purpose of the committee, we thought since we're starting a new cycle for planning for 2023, it might be good with new members and just to kind of remind everybody of the purpose of this committee. So the Health Plan Benefits and Qualifications Advisory Committee makes recommendations to the board for the qualified health plan certification requirements, which include the annual standard plan designs. The ACA requires the exchange to establish these requirements for certification, recertification, and decertification of qualified health plans. And so this committee does very important work making recommendations to the board in this area. So later, a little bit later in this meeting, we'll review the full list of the various certification requirements that the committee does consider from year to year as part of our presentation today. And then just to touch on the membership of this committee, it includes several board members who are with us today in different areas of expertise, which is wonderful. Also representatives from both carriers that offer plans, actually all three carriers technically for 2022, offering plans through Access Health Connecticut. We have a consumer advocate member, an insurance industry business consultant, a subject matter expert from CID, representative from the Connecticut Hospital Association, also from the Connecticut Pharmacy Association and the Connecticut Association of Optometrists. So I think we've got a good mix of stakeholder input for the committee's work.
Okay, thank you. Next, since there is no public comment, I'd like to have a motion to approve the minutes from last May's meeting.
This is Ted, so moved.
Thank you. Seconded?
This is Jill, second.
Oh, hi, Jill. Okay, you're on.
Hi,
You're in
here
now. Yeah, you're here now. Okay. Any comments or suggested changes to the minutes?
I don't know, I see that.
Oh. If not, Marson, can you call the roll?
Sure. Frank Ritter,
Yes.
Tito
approved.
Dolo,
Aye.
Mark Schaefer,
No, Bubba.
Mark Schaefer,
No.
Matthew Brockman,
Aye.
Manisha Jutani,
Yes.
thank you. Neil Kelsey,
Yes.
Tun Cohen,
Yes.
Ellen Skinner,
Yes.
and Jill Zorn.
Aye.
Thank you. Motion passes.
Okay. If you could mute your phones when you're not talking, we're getting some feedback here. Thanks. All right. Susan, I guess it's time to look at the vision and the mission.
Look at the vision and the mission. Yep. Thank you. Thank you so much, Grant. So here is the Access Health vision and mission. And we just wanted to point out to everybody that Access Health Connecticut was created in 2011 by the Connecticut legislature, and the board adopted the mission, vision, and principle statements that are in use right now in 2012. And after nearly 10 years of operation, we feel it is the right time for the board to review these statements and determine what changes might be needed given our growth and development over the years and the current state of our work and future plans. So we just wanted to mention that is something that the strategy committee and the board are considering at this time.
Hello, this is Charmaine Lawson, Plan Management, Access Health. You may notice that we have redesigned the look of the values in action logo. Our values and behaviors have not changed, only the layout. We have recently incorporated values into the Access Health CT Employees Performance Review that kicked off this week. Employees will have behaviors associated with each value-based performance category and will have to rate their performance by entering comments related to their performance in these areas for their managers to review. Next slide. Most of you are familiar with this diagram. This is the plan management certification lifecycle. Once they release the draft federal regulations and guidance, including the draft actuarial value calculator, the AVC tool, the plan management lifecycle begins. This helps in guiding us along with the assistance of this committee, who assesses the need for the certification requirements and provides input each year when we meet to start developing the standardized plans for the renewing year. Next slide. This slide is the current landscape of the individual market. The first grid displays all the plans in the individual market on and off exchange by metal level. The second grid is by product type. Chi-Chi, who was only off exchange in prior years, now offers plans on exchange for plan year 2022. Any questions on this slide? Okay, next slide. This grid displays all the products offered on the exchange by metal level. They are displayed in the order of the least to the most costly. I'll give you the definition for each product. The first one is the HMO maintenance organization. So that's the health maintenance organization product. You are required to utilize doctors within the specified network and must select a primary care physician. PCP referrals are required to see a specialist. Only covers emergency services when out of network. The POS, which is the point of service. 1 second here. Oops. You are required to utilize doctors within the specified network and will be required to select a primary care physician. Referrals are required to see a specialist. Out-of-network doctors are covered at a higher copay or coinsurance amount. And then we have the EPO, which is an exclusive provider organization. You are required to utilize doctors within the specified network, but generally networks are more expansive than an HMO network. They may or may not require referrals from a primary care physician, only covers emergency services when out of network. And please note, with the addition of Chi-Chi on the exchange, for the first time, we will be offering an EPO product. Then we have the PPO, which is a preferred provider organization. This plan offers in and out of network coverage. Out of network doctors are covered at a higher copay or coinsurance amount. It allows you to see specialists and out of network doctors without a referral. Next slide. This grid is a comparison of all the individual plans that were filed with SID for plan year 2022 for both on and off exchange. For plan year 2022, Access Health will offer a platinum plan. As noted, currently there are no platinum plans offered off exchange. Next slide will be for Susan.
Thanks, Charmaine. And this is what I was referring to earlier. This is a list of the different certification requirements that the committee looks at periodically. The Essential Health Benefit Benchmark Plan, which actually the committee does not review, that is determined by the state, by the insurance department. But the prescription drug formulary, tobacco use we've looked at in the past, broker compensation, network adequacy standards, ECP contracting standards, pediatric dental coverage, requirements regarding the lowest cost silver plan in the market, the plan mix, which is what types of plans can the carriers offer, standard and non-standard, and the total numbers at different levels, for medical and also for standalone dental and shop. And also what this committee works on very dedicatedly, I don't know if that's a word, is the standard plan development that we're going to talk about today for the individual market. And just a reminder, we do not require carriers to offer standardized plans in the small group market. We do dictate the plan mix and the number of plans allowed, which we'll get to, but we don't have standard plan designs. But in the individual market, we do use standard plan designs for ease of comparison and shopping for consumers and a variety of, consumer reasons that we'll cover when we look at the plans and the cost sharing. So for 2022, that was the only area that the committee made changes in, and that is the proposal for 2023, that is the area that the committee, will focus on. If anyone has any questions.
Yeah, this is Jill. I have a couple of questions about if this committee isn't going to look at it, who is? And one of them has to do with the sheer number of choices that are now sitting in the gold and bronze areas, especially. It looks like we had 11 bronze plans and 10 gold plans. And I can remember at the beginning of the exchange, we worked hard, at least on the consumer side. And actually, it was approved ultimately. We tried to make sure there wasn't, quote unquote, too much choice, an overwhelming amount of choice, because the literature shows that too much choice isn't necessarily good for consumers, especially when there isn't that much difference between some of these offerings. So I feel like that as the number of gold and bronze has accumulated, feels like it may be getting out of whack, at least ought to be getting discussed, whether we should be limiting, going back to what I think we changed the limits a few years ago, might have been even before I joined the committee. So the concern about choice is something that I wonder if that's some, what's the right amount of choice? Is there enough difference between the different plans on these tiers to justify having so many choices? That's an issue I feel
we go
someone
back
ought
to
to talk about.
the slide, I think it's 8 or not, yeah, slide 8.
Sure. And just to point out, Jill, a big part of the reason why there are more offerings at some of those levels, if you go back one more, I think, Martin. One more before that, sorry. So you show everything on and off exchange.
There it
Thank
is.
you.
Yeah.
As we mentioned, we have an additional carrier in the marketplace this year. Connecticut Insurance Company,
Yes.
Inc. is offering plans on exchange for the first time. So that increases the number of offerings, at all of the levels. Certainly, obviously, they're required to offer the standard plan offerings, and then any non-standard plan offerings they may be offering. So the number, did probably increase for 2022 as a result.
Right. And I remember originally when this exchange opened, we had 4 carriers, and actually they were actually 4 distinct carriers, not, one carrier that has 2 different subsidiaries. And that was when we did try to limit choice, partly because of that. So I think it's a legitimate issue to look at, and I just want to know if that's business for this committee or the consumer committee that hasn't met in a number of years. But I feel like we ought to care about that. Somebody has to care about that.
That is something that this committee would consider. That was listed on that slide. That would be the plan mix, the number of plans the carriers are both required and allowed to offer. So that would be something, the committee could discuss if it chooses to.
Thank you.
Yeah. Could I, what is the current mix allowed? I know that only one silver plan is allowed, but what is the number of bronze and gold plans that are allowed?
I think, Charmaine, if we go to the next slide. No, actually, we'll get to it. If we keep going in the presentation, Grant, sorry, there is a slide that shows us that for both individual and for shop.
Yeah.
Okay.
Okay, so maybe we'll move on to the next slide.
I'll just point out too that on bronze, there's actually 2 standard plans, right? One HSA, one non-HSA.
Correct.
So 6 of those 11 plans are standard plans.
Are standard plans. That is correct. Okay, so do we want to move to the next slide, Martin? Thank you.
Hello, everyone, and Happy New Year. I'm Julie Andrews. I'm a senior consultant with Wakely here in the Colorado Denver office, and I'll be presenting today with my colleague Brad Haywood. Today, we're going to go over the regulatory changes that are occurring for the 2023 plan year, going over some of the statutory changes as well as regulatory changes and updates to the federal AV calculator that will add the constraints that we'll need to comply with in developing the 2023 plans. If you advance the slide, Martin. So the 2023 benefit and payment parameters is out, and the NBP is the regulation that divides many plan elements, including the maximum out-of-pocket that we're required to comply with, as well as for the cost sharing reduction plan variations. The 2023 proposal is to increase the maximum out-of-pocket this year from $8,700 to $9,100, with additional increases to the CSR variations as shown on the slide. The $9,100 MOOP is a 4.6% increase over the prior year's maximum out-of-pocket. And this is defined by statute as the 2014 year limit that is increased annually by the premium adjustment payment index percentage. And so with the application of that percentage increase, that's how we get to $9,100. If you recall last year, the initial 2021 limit was also $9,100, but was eventually lowered to $8,700. When the new administration came into office, they made a change in the calculation of the driver of the premium adjustment payment index percentage, and they tied it to the average per enrollee employee-sponsored insurance instead of looking at all private health insurance. So that's why the dollar limit was lower last year. The second constraint we have is for our HSA plan, and that is the IRS regulation on the maximum allowable MOOP as well for high deductible health plans. The current limit is set at a minimum of $1,400 and a maximum of $7,050 for 2022. Unfortunately, the limits for the coming year usually does not come out till 2023, until May. So we'll have to wait a few months before we'll get that final number. So we'll just have to take that in consideration as we've done in prior years about that potential limit change. The third regulatory constraint, which isn't listed here, but that we always need to take into consideration is mental health parity. And so we always make sure that as we're defining the plans that we work with the carriers that are on the exchange, that any plan changes will comply with mental health parity testing. If we go ahead and advance, there's additional regulatory and statutory elements that are going to come into play in 2023. The first is the expiration of ARPA and the expanded percentage of income index limits that are set to expire at the end of 2022. This will have a significant impact for many individuals as far as their advanced premium tax credits they'll be eligible for 2023. Initially, extension of the expanded limits beyond 2022 was currently put in the Build Back Better Act, which I guess politically we could say right now is a non-starter and in its current form. And the administration seems to have now switched their focus towards voting rights. So we may not know, until much later in 2022 what the environment will be in 2023 as far as advanced payment tax credits for enrollees. An additional unknown, I believe, is whether the current Covered Connecticut program will be extended into 2023. The program was established last year and is continuing in 2022, providing additional cost-sharing protections for those individuals who are ineligible for Medicaid due to their income level. And currently, the income range is set from 138 to 175% of the federal poverty level. So let's talk about the federal actuarial value calculator. If you want to advance the slide, Marcin, thank you. So the plan analysis for 2023 will again use the federal AV calculator tool. The calculator tool will continue in its same format using the same service category, cost sharing groupings as prior years to determine the actuarial value and meta level of the plan. For 2022, there had been no changes to the calculator from 2021. This year, several changes are occurring. The underlying data is being updated to reflect experience from the 2018 experience year. Each metals plan's data tables will reflect experience from that base year. And so the impact of the data updates will vary by meta level. So, silver AV calculator cost sharing data will be based on 2018 silver data and similarly for bronze, et cetera. Now, since we're talking about 2018 data, there will be trend that will be applied to bring the data current up to 2023. And the trend adjustments will vary annually. Medical trends are lower, ranging from about 3 to 6% to bring the data current to a 2023 estimate, while pharmacy trends are higher from 4 to 9%, driven primarily by higher cost trends experienced in pharmacy. Additionally, one of the other things that they did was in the underlying data, there's been obviously a different change in the demographic makeup of the exchange from 2018. So they did make adjustments to the data to reflect a 2018 age mixed population. They're also proposing changes to the metal level de minimis ranges. The 2018 NBP had expanded the ranges in order to create flexibility and promote competition in the marketplace. It was also anticipated that the changes would provide flexibility for issuers to maintain cost sharing within a metal level. Since 2018, CMS has observed a concentration of plans at the higher end of the expanded bronze range, which allows AVs up to 65%, while when looking at the silver range, only about a third of plans were offered at the expanded lower silver range, which runs from 66 to 68%. So CMS notes that while the higher bronze and lower silver had similar AVs, the significant cost sharing differences remained, and they felt that that might have been confusing to consumers. Similar enrollment distributions were observed at the gold medal level, where there was a pretty even distribution across the gold AVs. CMS is hoping that by narrowing the range for the silver plan, it will increase the generosity of the second lowest cost silver plans that may be currently offered at the lower end of the de minimis range. And CMS continues to anticipate and continue to promote the expanded bronze plans at the top of the range. Instead of providing the ranges here, I'll let Brad present them later on in the presentation. I will comment that this constraint on the ranges will likely have no impact on the Connecticut standard plans, because the plans were generally offered at the higher end of the de minimis range, and where they're constraining is at the lower end. The tool is still in draft format, so as we go through and do the process of developing the plans, we'll just need to understand that the parameters may change at the last minute, as experienced in prior years. If you go ahead, Marcin, and go to the next slide. There are some statutory elements that we also always need to keep in mind when doing the cost sharing for the standard plans for the new year. At this time, we're unaware of any active legislation during the 2022 session that may impact the plan design process for 2023. From 2022, the regulation regarding coverage for diabetic drugs, insulin, and medically necessary diabetic devices was added. This regulation sets maximum copays and cost sharing for services over 30 days. And the Connecticut Insurance Department had provided guidance on the accumulation rules for the cost sharing on medically necessary devices over the 30 days. And finally, we went, the committee and group went through a lot of consideration as to how to accommodate the regulation with regards to high deductible health plans and how the cost sharing limits will interact with the federal regulatory rules and limits. Additionally, going on to, you've got that up. Thank you, Marcin. The standard plan also must comply with standard cost sharing regulations regarding the physical therapy copays and the advanced imaging maximums. So that's it with regards to the regulatory update. So we'll go ahead and advance the next slide, and I'll turn it over for Brad Haywood from here.
Great. Thank you, Julie. Now, to start off, I just wanted to give a brief background into the AV calculator and to the federal actuarial value calculator that is released from CCIO, a branch of the CMS government. This calculator, the overall purpose is to estimate the portion of medical claims that would be paid by the carrier or by the insurance company. This portion, there are different targets depending on the metal level of the plan. For gold, that would be an 80%. For silver, it's 70%. And bronze, it's a 60%. This means that the calculator is defined to really bucket those metals into plan designs that would fall into those percentiles for the different metals. Now, as Julie mentioned, in 2022, deviating from the 80, 70, or 60 percentile, there were ranges that the different plans could fall into that were wider than what are proposed for 2023. As seen in the first row of each of these tables, starting with gold, the range was 76 to 82% of the total cost that the carrier would be responsible for. For silver is 66 to 72, and bronze 56 through 65. For 2023, these de minimis ranges, or these AV ranges, have decreased to plus or minus 2% for the most part. For gold, it's going to be 78 to 82%. And then, similar to what Julie was mentioning, for silver, it has come down even more to just be 70% to 72%. And then with bronze at 58%, but then also up to that expanded bronze definition, which is higher than the plus 2% at 65%. Now, what also we're showing here are the 2022 plans, how their AVs were modeled for the 2022 plans that came out for this year. As part of this, we asked the carriers to test the AV in their calculators, and what we show on row 3 are their responses in addition to Wakely's analysis as well. And as you can see, the ranges do fall, what we're showing in row 3, they do fall within those permissible AV ranges. Now, what we see in the bottom row is Wakely reviewed the 2023 draft calculator that was released earlier. And as part of that, with the update to the data, update to the trend and the population adjustments, putting the same benefit design is what we have for 2022, put the same benefit design into the calculator. What we're seeing are changes to the AV. For gold, it was a smaller change from 0.2 to 0.4. Obviously, depending on the inputs, this could vary. We have seen this be a bigger impact with other plans. But silver, we did see a much larger increase, where gold was only 0.2 to 0.4. The silver AV increase was about 2%, if not more, for these plans. This increase would mean that more benefits would need to be changed in order to drop back down into that proposed AV range. The bronze had a smaller impact. They increased 0.1 to 0.3%. And in addition, the HSA actually was showing a decrease of about 0.3 to 0.7%. So while others were seeing big increases such as silver, the bronze HSA, we actually did see a decrease to the AV range there. And while I didn't cover the numbers in particular, we do have for the CSR plans, for the silver CSR plans, what the AV ranges look like for them, and as well as where the big changes were occurring with the draft 2023. Really, the main picture here is the silver plans are going to be in need of more changes in order to fall into that permissible AV range for both the silver standard and the 73% are going to have the biggest changes there. We can jump to the next slide, please. Perfect. Just as a brief history of what we have done in prior years for changes to the benefits, we wanted to lay out what we did last year and some items and subjects of benefits that we have changed in prior years. Now, for those that are new, last year we made changes to the lab services. This was in response to, as Julie had mentioned, last year the calculator had very minimal changes. In fact, there really were no AV impactful changes made to the calculator, which gave us room to make changes to the benefit to actually enriching the benefits for the consumers. Part of that was putting lab services before the deductible or not subject to the deductible. In addition to that, we did incorporate new state legislation concerning services related to diabetic care. For previous years, before 2022, other items we had updated, and as well for 22, were changes to the deductible and MOOP. Those are always going to be more impactful changes. But in addition, we have made changes to lab copays, to ER copays, to outpatient copays, split by facility type. But one thing we did want to mention here is when we consider any benefit changes to be made to the standardized plans, especially within the AV calculator, it's important to understand that certain benefits, such as a PCP copay or specialist copay, are going to be more impactful to help drive changes to the AV. This is due to higher utilization flowing through to those benefits. Other benefits may not be nearly as impactful, which is why we typically will stick with deductible and MOOP changes, or small changes to more higher utilized benefits, such as PCP copay or specialist copay. Now, for this year, there are new legislation. The main one is an age change for dependent dental from age 19 to age 26. Now, the AV calculator, the federal AVC, does only look at essential health benefits. So it is only a predefined set of different benefits, which does not include dental. So this change in the legislation would not be impactful for the 2023 AV calculations. And in addition, lastly, we just put that potentially, if there were other reasons to make changes to the plan designs, it could be to offset premium rate increases. This was an item of focus last year, since there were no changes to
I can't hear Brad. Are other people?
Yeah, I think he froze for a second.
Okay. I thought
Yeah,
it was me.
this is Julie here. Yeah, Brad, you are frozen. I'll reach out to him, but I'll go ahead and take over from here until he can rejoin or reboot his computer. But if we go ahead and advance on to the next slide, what we'll do is go over the 2022 plan designs. So the 2022 plan designs, as of now, we have reached out to each of the carriers, but we have not received yet from them their 23 scoring of the 2022 plans, and they haven't been reviewed by AV calculator or for mental health parity changes that may be occurring from their 2022 analysis to date. As you can see, on the next slide are items that are defined in the plan designs, but as Brad mentioned, are not key components of the federal AV calculator. So there is cost sharing elements associated with each of these services, but they are not, specific to the AV calculator. Oh, okay, Brad is back on. Brad, I was just letting everybody know about these services with cost sharing, but that are not impacted in the AV calculator. So if you want to go on to the next slide.
Great. Thank you, Julie. Yeah, apologies there. My internet went black for a minute, but I'm back. Thank you. Thanks for taking over. Yep, we can jump to the next slide. A few additional notes as we start looking into the plan designs, the cost sharing that we will be looking at on the following slides. It will represent only the in-network services only. There are out-of-network that will be covered under the standardized plan design, but what we will be showing will be in-network only. In addition, the deductible and MOOP limits, which will be shown, are for individuals only. The family limits are typically 2 times the individual limit for all plans except where noted. Preventive care is covered at no cost to the member for all plans. Mental health cost sharing is going to be the same as primary care for all plans. This is in response to an item Julia covered to help satisfy mental health parity. Silver loading for defunded cost sharing reduction plans will likely persist in 2023. And all plans will include embedded deductible approach, not an aggregate deductible approach. Next slide, please. To start off, here we have the current 2022 gold plan. The gold plan design, which has a $1,300 deductible and a maximum out of pocket of $5,250 for in-network services. And in addition here, what we have included are changes that were made in 2022, such as a $25 for each 30-day supply of a covered prescribed medically necessary insulin or non-insulin drug, and $100 for each 30-day supply of a covered medically necessary device or diabetic device. This is in response to the diabetic legislation. And as we had seen on a prior slide, the AV range we were looking at was that 81.6% to 81.76%. This represents both the carrier's testing of the 2022 results as well as Wakely's AV testing. With the draft AVC for 2023, we are seeing about a 0.2 to 0.4% increase to the AV, which looking at where the AV currently is for 2022 would push that up to the very high range, close to the 82, potentially surpassing the 82% high range.
Brad, this is Julie, if I could interject. So, when we get the feedback from the carriers regarding their 2023 valuations, the gold plan may still be compliant, or it may require minor changes. In the past, we've focused on like the medical deductible or the maximum out of pocket as the lever used. So I think, to get some feedback for the next meeting as to what approaches we should take as far as testing plans or modifying plans to bring them into compliance for 2023 if necessary.
Could you review what's the maximum out of pocket for next year?
It's proposed at $9,100.
Ooh. For
And
a single
this
person?
plan is currently at $5,250.
Oh, yeah, we're way under. Okay, yeah,
Yes.
all right. Okay. Well, we don't have to make a big adjustment for gold, do we? Because it's only like 0.1 to 0.3.
And I will note, Grant, that we have asked the carriers to test these plans as well. Since this is based off of Wakely's inputs, it can obviously vary depending on carrier of what adjustments they make. So it could be different from the 0.2 to 0.4% increase we're showing, but yeah, it's not as impactful as what we saw for silver.
Yeah. Well, my own suggestion is to, raise the out-of-pocket maximum a slight, as little as you can to get it below the 82, or that would be my suggestion, but I welcome anybody else's input. Any other ideas?
Well, we don't have to decide right now, right? 'Cause
No,
we're
we don't
still
decide.
looking
It's
for
just they want
permission.
some direction. Yeah.
Yeah. We'll see.
And Grant, I think that sounds, fair and reasonable. We, like I mentioned, just, Brad and I would like some guidance, for defining testing requirements for the issuer. So we're not, doing a bunch of different scenarios and trying to be efficient. So I think that sounds good. I'll let you go on to the silver plan, Brad, then.
Okay, perfect. Thank you.
Yeah, here's where we're going to have to make an adjustment, a sizable adjustment.
And I'll just make a note, the 2022 AVCs were closer to the 70%. So they were anywhere from 1.3 to 1.2% below the high
Right.
end, but they still will be over the high 72% based upon our testing.
Mhm. Well, at least for the individual, the 70%, I would again say, move the out of pocket up. It can't go beyond 9,100, but it's only at 8,600 now. Is that 9,100 assured, or might they change it down again?
They could, Grant, we don't know. This is just the proposed rule, but I think it
Right.
is interesting to note that last year, the initial draft MBPP that came out from the prior administration at Health and Human Services started with a $9,100 max out of pocket. And then when the final regulation was passed by the current administration at HHS, they went down to the 8,700. And now they've gone back up to the 9,100 in their proposal for this year. And Brad and Julie, was there information I forget, that talked about, the rationale? I think Brad may have covered that, or Julie.
Yes, yeah, the reason is they changed, because normally, as I mentioned, that the MOOP is driven by 2014 levels trended forward at the premium growth percentage, and they changed the metric way which that is measured. Premium growth is measured, so that was the driver last year.
Mhm.
And I think that they haven't indicated they're planning on changing that factor this year.
They
since
have or
did
haven't?
last year.
Oh, they did. They changed it last year, so they're probably going to sit with it for a while, right?
Mhm.
Yeah. Well, I would again. Yeah, I sort of do remember they moved it. It was higher, and they moved it down, and they might do the same sort of thing to us this year. But I would play around with the out of pocket, see how sensitive it is to raising the out of pocket in order to get us below the 72. With the understanding we don't need to get down to 70 and a half again like we were last year, but anything under 72 would be acceptable.
Grant, this is
Yeah.
Ted.
Yeah.
Just to kind of add to the conversation here, when obviously we raise that maximum out of pocket, that means that those dollars are exclusively going to be coming from families that are hit with a big sickness or a big disability. So that's not, we got to keep that in mind. I'm not saying not to do that, but we have to keep in mind that what we're doing then is we're making it so that only families that are up near the top already of the MOOP are going to be paying the additional. And so, as distasteful as it is to consider some of these other income or revenue, generators, like the co-pays and so forth, I think it's a hard question, and I don't, I hope we can have a rich discussion around this. I'm not saying that Grant's basic approach isn't acceptable, but I think we really have to think it through.
Yeah, no, I agree. It's a tough choice. I guess the thing that sort of always sticks in my mind is the way healthcare insurance works now. Something like 85% of people with a bronze plan never see a single dollar in return. The silver plans are a little better. It's probably not that big a percentage that don't see any return at all, but people are putting in very high premiums, $500, $700 a month, and not getting back anything. And because all the money is going to the person with the $30,000, $40,000, $50,000 hospital bill, and it's a tough call. I mean, do you make that person pay an extra $500, knowing that they're getting $50,000 covered, and they have to come up with an extra 500, or do you spread that money out among the people who are right now getting very, very little back from their premium, admittedly with much lower medical costs. So it's well worth a discussion. I agree.
Right. And to remember as well, those individuals under 250% of the federal poverty level are eligible for cost sharing reduction incentives. So there are some protections built into for
Right.
those individuals that are at the lower income levels.
Yeah, I'm always, and I think we went through this last year. I'm always trying to get more and more of the benefits pre-deduction, not subject to the deduction. And we worked very hard last year to get the lab services that way. And that seems to be the one alternative
This
to
is
raising the
Ellen.
out-of-pocket.
You know, one of the things I always find helpful is if we look at a cross-section of the people in terms of the plans they chose and what it actually costs them in terms of premiums and out of pocket, to see how much of a differentiation there is. And I don't know, we have enough years experience. Could we get some of that information?
Actually, they were just this year they started being Ted's always really asked, strong on that issue. And I think this year we finally did get some
because at the end of the day,
information
I
about
think it should be equitable for
true-
everyone in terms of what they put into it and what they get out of it, and in relation to their ability to pay.
Right.
In
This
that
is-
regard, just to chime in real quickly, I'm sorry, I know I just cut somebody off, but just to chime in real quickly, the actuarial value is a terrific measure, and it's needed by the insurance companies, but it's relatively meaningless for the consumer. And I have been advocating for moving toward, can we also provide alongside the company level AV or the community that's insured level AV, like an AV for the median consumer or an AV for the 25th percentile consumer. And that way we can see the impact on our customers while it's perhaps a little more clearly. And I know, as was mentioned, we have started to take steps in that direction, and I hope we continue down that path. I'm sorry, whoever I cut off, I apologize.
Is it Ellen?
It's Jill.
Jill. Oh, okay.
Yeah, that's okay. I was interested to hear which are the variables that affect the AV, that the AV calculator pays the most attention to. And I was wondering, so if you changed the inpatient hospital deductible, for instance, I'm not saying, I can't even tell if that's a good idea or a bad idea, but it looks like this benefit might be similar to what's in the gold plan. Is it just because so few people end up in the hospital that if you make that a little worse, it just doesn't have enough impact? Or is it worth looking at?
I would say that the inpatient would be worth looking at. It's definitely going to be more impactful than your chiropractic care or rehab or any of those, or even the all other medical. Your most impactful, obviously, are deductible and MOOP. And then the high utilizers such as primary care, your specialist, and generic copays. But Julie, correct me if I'm wrong. I would say inpatient could be one that, while it might not drive a 2% swing, could be more impactful.
Yes, yeah, we can take a look at that and see how that might impact results.
Trying to decide whether to futz with that or like increase generic drugs by $5, I have to really, I don't have an opinion right now, but it's because there is something about these maximums are getting so high. I mean, yeah, it's no good answer. I mean, with the hospital now, these people are thrown on the mercy of the hospital system to handle medical debt properly. But I mean, that is an area that's being somewhat regulated. It isn't completely unregulated now, and there's some protections for people, probably not enough, but it is. But these are big, huge organizations that probably have some ability to cut people some slack when they can't pay their bills. whether they behave properly or not, you know, I mean, it's pretty complicated. Maybe we need better help for people with medical debt than we've already given them, but I know it's definitely an area that's been looked at, and at least it sort of spreads the costs partly to another institution that might be able to afford to not, you know, collect everything. On the other hand, these are institutions that garnish people's wages and do, you know, it can put them in a bad situation too. So I'm not sure what the right thing is to do, but might be worth looking at.
Could I ask how sensitive is the AV to the urgent care? If there's swings in urgent care, is that truly impact the AV, or is that not a big ticket item?
The urgent care is actually not part of the federal AV calculator. It can be set equal to specialists or others, but urgent care does not impact it.
Thanks.
Right. I mean, if a carrier feels like they have a significant utilization in urgent care, they can make adjustments outside of the calculator to reflect, you know, that cost sharing and that impact to the AV. So there are, you know, opportunities where actuaries can adjust the federal AV calculator, which is why you see a range coming from each of the carriers. To reflect uniqueness in their benefit designs as well as their utilization.
And this is Jill again, as far as things, because I think we are actually, this one, you definitely have to do several different analyses. And I don't see trying to increase primary care specialist copays that are already awfully high. That's my opinion. I don't know what other members of the committee feel, because you said those are also sensitive, but they are already seem mighty high.
Right.
And then I just don't, what about outpatient hospital? I mean, hospitals probably half their business practically is outpatient. Is that worth looking at or not?
I think Julie and Brad, didn't we sort of look at that, and Brad touched on it with the site of service a little bit a few years back?
It has been an item that we've adjusted before, and that's why you see the 300 ASC
Oh.
500 because it's split by facility type.
Right.
As far as the impact, again, it might be one that we have to go back and really take a look at to see how impactful, but we have adjusted it before.
Okay, thank you.
Yep.
That's after the medical deduction, right? So if they did have an outpatient
Oh,
hospital
that is pretty bad, huh?
stay,
I
they
didn't
would,
think
they
of
would
that.
pay the first 4,300.
Yeah,
Maybe they pay another 300 and that's it.
it's not going to
So,
help. Yeah,
Yeah.
that's already bad that it's after the deductible.
Yeah. That after the deductible makes the inpatient and outpatient less impactful than they would have been otherwise.
But at least the inpatient has some kind of maximum there. Well, I don't know. I don't
That's per stay,
understand
though.
that exactly.
Yeah,
After the
it's a little
2000 or-
confusing, right?
Yeah,
I still think they have to make the deductible, which is $4,300 on their stay before they limit themselves to $500 a day.
although it says 2000 max, so it is confusing.
Yeah, no, but I think that lessens because it's only covering between the 4,300 and whatever is the hospital bill. Okay.
I'm sorry, why doesn't for a given discharge, I don't understand why it wouldn't be limited to 2,000?
Because it's after the deduction.
Oh, I see. Yep.
I know. Okay. One question. What are, could we see sort of a list of the limits that the Connecticut state has for different kinds of services? I know that they've raised them from when we started doing this 7 or 8 years ago, but are any of these amounts below the max for the state? They may be now. They weren't originally, but things like rehab and habilitative services, for example.
I believe.
This,
Oh, go ahead.
Grant, this is Paul Lombardo.
Yeah.
We did away with the maximum copays
Oh,
a few years ago.
yeah.
The only maximum copays Julie and the group went over that are statutory maximums, that are caps. We don't
Uh-huh.
have any CID internal caps for cost sharing.
Okay.
Yep. So we are at the maximum on the silver for the $30 physical therapy
Oh, that's
copay.
just the one I was
under-
talking about. Yeah.
Yeah,
Yeah,
and as well as the $75 on the advanced radiology. For
Those are the two I
so
was looking at.
yeah.
So, yeah. They seemed a little low to me, but that's why, because okay. I don't see many places to go.
Well,
Definitely.
I think Brad and I have enough to take away from, and I know that getting an idea of how healthcare dollars are actually spent by consumers is continues to be a key theme, and so Brad and I'll also take that as a takeaway as to how we can round out that picture for the committee.
Okay, great.
Yep.
So I guess
This is why
advanced.
this is not a fun committee to be on. This is a tough committee.
This is Mark. Schaefer from CHA. I was wondering, do we know anything do we have data, have the plan shared data about the extent to which avoidable use, the wrong use of the wrong services is driving premium? So for example, with such a hefty primary care cost share, you're getting folks to avoid primary care. And is the effect, is the road we're going down basically creating more of a barrier to access that eventually manifests in emergency room or inpatient hospital use? And, the comptroller's office for many years was a proponent of value-based insurance designs, and I don't see any thinking in these benefit structures that's designed to incentivize ensuring that patients, say with ambulatory care sensitive conditions like asthma or diabetes, are incentivized to ensure that they're adhering to their care plan and they're getting their medication, that sort of thing. So I'm just wondering if the conversation limited to sort of what's the least objectionable place to increase the spend, we're not doing anything to try to solve for more cost-efficient use of the healthcare services that's good for patients and good for benefit trend.
It's completely right, Mark. Completely agree that our problem is that the AV calculator does not like value payment design. And we've actually tried before. And I mean, it's only because the insulin law passed that we have a little bit of it now just for that one condition. But every time you lower costs, with obviously the goal to have long-term impact. Whoops, I gotta go. But anyway, you're just not allowed. I just have to take a quick break.
Yeah, and this is Julie.
Oh, sorry, Julie.
Yeah,
sorry, I was just going to add that in addition to having to work with the parameters of the AV calculator, we also have to work within mental health parity. So the plans have to be able to pass on both AV and parity. And we have seen in the past, when we've made various tweaks and changes, that sometimes can wind up being an issue for us for one or both or all the carriers in that realm.
I see. So is our mental health visits, routine outpatient mental health visits, subject to the primary care or specialist copay level?
Sorry, routine what?
Routine outpatient psychiatric or substance use services, are they subject to the 60 or the 40?
Probably the 60.
It depends on the calculation of the parity, but I believe that it is the 40. I can confirm that.
Yeah, and so it also would apply when you start looking at the inpatient and the outpatient too.
Mhm.
Yeah, I believe this chart only shows really what impacts the AV calculator. It doesn't, it's not a full benefit description. I don't know if you've included that later in the deck, Julie, or because I know at times we see a broader, fuller benefit description.
We can get that put together for the team. I think that usually comes in as an appendix, or the larger, more detailed description, as well as those that aren't part of the AV calculator.
Right.
Susan, are you providing that information, or
It
work
may
with?
be, yeah, we have a big appendix, Neil, and everyone, that we always include in this deck, so we can get to that, and everybody has a copy of the whole deck and has that. So I think we have the plan designs for this year in the appendix, so that may have more of the cost sharing information listed.
Yeah, you
in
do.
that.
Yeah, I see it on like page 39 for the standard bronze.
Yep.
37 for the standard silver. So
Mhm.
so yeah,
Yeah.
the mental health, behavioral health, substance abuse is all under the primary care, at least for the silver.
Thank you.
I remember seeing them someplace.
Mhm.
Well, I think Brad and I have enough to go on with the silver if you want to advance to bronze. Thanks, Brad.
Yeah, similar discussion here. Obviously, we don't have the same increase to the AV in the 2023 draft federal calculator. Here we are seeing a 0.1 to 0.3% increase based on our testing. I'll also mention that similar to the HSA plan, for other plans, I have seen a decrease. So just depending on the benefits that are flowing through is what we're seeing there. But the bronze non-HSA would be a much smaller impact there. So I'll leave it open there if there is an appetite to make an adjustments there, given that the 2022 AV results are closer to the high end of the 65%, might still warrant some small changes to the non-HSA plan.
Yeah, I think the first thing to do is see whether any change at all is necessary, or whether we're just creeping a little bit closer to that, maximum, whatever it is, but still below it. 65, I guess, is it? Yeah.
Yep, below 65. Yeah, and
Yep.
as I mentioned, the carriers are going to respond to us with where their
Yeah.
AVs are. Once we hear back from there, we'll have a better picture of what kind of adjustments will be necessary. And you're right, we might already be below 65.
Yeah.
Okay. I think we're good there then. Moving forward to the bronze HSA. This is the one that we saw a slight decrease. Since we were already compliant, that means that we would still be compliant under the 2023 draft ABC. I don't know if there's any discussion on potentially changing those premium or changing the benefits for offsetting premium increases or anything, but as far as from a federal calculator standpoint, from what we're modeling, we're seeing that it would be compliant still.
Any observation? Again, I wouldn't worry about it. I would just
Okay.
let it ride. It's my opinion. I mean, we could lower the out of pocket, I guess. I don't know how much we could be able to lower it though. And we're pretty much close to the top, even with a 0.7% decrease. So I can't imagine we'd be able to lower the out of pocket too much.
Yeah, and the other note on that, the deductible is at 6,500. So right there, there's only a $500
Yeah, it's very
gap.
tiny little window, isn't there? Wow.
Mhm. Mhm. Okay, we will move forward with keeping it as is, and we will turn it back over to whoever's got this slide.
Thank you, Brad and Julie. And I'll actually, Martin, if you could move forward just quickly to slide 44. We'll just go through in the appendix. This is where we have listed the slide we mentioned before in response. Thank you for Jill's question about the plan mix. So just to show everybody. So this shows in the individual market on the left side, the standard plans that the carriers are required to offer, the number of them, and then the non-standard plans that they're permitted to offer. And so the total maximum. And then on the right are the requirements for SHOP, which has no standard plans, but just the required mix of plans that they're required to offer in addition to the optional ones. So just in response to Jill's question about the plan mix, the offerings that we allow for the carriers. And in some instances, the carriers don't even offer all of the, optional plans that we permit. So.
When will we see the results of open enrollment? When we can see a distribution by plan design?
By plan design, yep.
Yeah.
At the next meeting, at the February meeting, Neil, open enrollment is going till January 15th, which is this Saturday, I believe. So by the meeting for February, we'll have that information for the committee, and it'll be presented to the board as well. Yeah,
Good.
so we'll see how everything came out for this year. Jill, I don't know if you had a question. You were on mute before.
Yeah, I just realized that. Yeah, so I think that's great. Obviously, we want to have the data. That would be great. And from what I can remember, those under non-standard plans, I think maybe an initial, well, we made some changes also because we limited standard plan, we limited number of plans in silver altogether. So it isn't completely comparable, but I think instead of where it says 3, it might have been 2, but I don't remember, and whether you can go back and try to figure out what it was. But I think that might have been the change in gold and bronze. It went from 2 to 3, like, I don't know, a few years ago.
Yeah, it was probably a few years ago. We haven't changed any of those
Right.
in recent years, so.
And just the other thing, I've been talking to, I don't know, some experts on this issue. And I guess one of the things you want to also look at is like the different, especially gold. I'm really thinking about gold. Is gold, some of these, because our silver standard plan is such a high, we've always made it like bumping up against the ceiling as best we can. The difference between, and then when the people that have CSR help, actually the silver plans with the extra CSR help are richer than the gold plans. And so there can be some things going on where the gold plans are overpriced in some ways. And there's been some states that have been trying to figure that out. And also, is there enough actual difference between these different options? Because you want, choice isn't, obviously choice is good, but like we know, too much choice can sometimes be confusing. And are these differences in the non-standard plans meaningful in a way that adds, value? So there's a lot of different things that could be looked at about whether the gold plans are priced right even, and which I know we don't always do price, we do AV, but what they really look like. And there's definitely literature talking about gold plans can be overpriced sometimes.
I'd
Sorry,
caution us on concluding that gold plans are overpriced, especially relative to the silver plans.
Right.
Because you'll recall that silver plans have the
Because of
silver loading in it.
Yeah.
For CSR. So even though
Yeah.
and not everybody qualifies for an 87 or a 94% CSR plan.
Yeah.
Right. And also, as Julie mentioned, in the proposed rule for 2023, they are proposing to change the de minimis range for gold, I believe.
Yeah, that's a good,
somewhat.
that would probably be a, I
Yeah,
know
so
Neil
that,
doesn't like
that
when I
may
see good and
actually,
bad, but that feels like a good thing.
it'll most likely have an impact on the non-standard plans. I think given where our standard plan, I don't think for gold it would have an impact, but I'm guessing it could potentially have an impact for some of the non-standard gold plans.
And when we get the report about the distribution, I forget if we, because for the non-standard plans, like, is it known what the AV is for each one of those plans? Is that something that it gets assigned eventually before they go out, or it just, or do we not really know what it is?
Oh, we know it. I don't know if it's in this material because we just focus on as a committee on the standard plans, but
Yeah.
it's in the carrier rate filings because we have to provide all the AVs.
So if, as Access Health CT is pulling this information together about the distribution between the different plans, it could be helpful if it's possible that when you list those plans, you say what the AV is. And then I just had one other question also as you, I did not go onto the exchange this year to see what the plans are named. But I was wondering, you know, between the two Connecticares and also what's actually a standard plan and what's not. I guess we'll at least, when you list them, if you could say what their actual name is. I think you usually do. This is another area that I wonder if there could be some potential confusion. Can you tell which ones are the standard plans? Can you tell the difference between the different Connecticut options? I think I'd just be curious to see what they look like.
Right, they do have different names in the plan names, the Connecticut Benefits Inc. versus the Connecticut Insurance Company Inc. And also, correct me if I'm wrong, I think all of the standard plans have the word standard in
Standard.
the plan
That's
name,
good.
so.
Yeah,
That's
that is
good.
the
Yeah.
requirement, Susan, that
Thanks,
they,
Charmaine.
it's their name, yeah.
That's good.
Okay, yep. Okay, Martin, can you go back to the prior slide we were on? Sorry, the right after Wakely's presentation. Yes, thank you. So just to go over the timeline for everybody. So as we mentioned, the draft NBPP was released on the 28th of December, and the AV calculator draft was released on December 30th. We're holding our first meeting now. Then, you know, we unfortunately don't know exactly when CMS will finalize the AV calculator or issue the final NBPP. The comment period is short this year. It closes at the end of January. So, you know, hopefully they will get those, get the NBPP out and get the calculator out on the earlier side. That doesn't always happen. And then also, as Julie mentioned, there's always a later deadline for when the IRS releases the information for the high deductible health plans. So the plan is for this committee to do its work and be able to make recommendations to the board at the April board meeting. And then that allows us to release our solicitation in late April so that we give the carriers enough time to do all the work they need to do on their end with their benefit and rate design and filings, because they are due to the insurance department and to Access Health in early July. So we try to get that all out by the end of April so that we give them several months to work on that. So that's our timeline. If you could go to the next slide, Martin. So just reviewing for the health plan benefits and qualifications meetings after today's meeting. Our next meeting scheduled is for February 24th. So we'll go over some of the items from today that Julie and Brad have and get some information from the carriers. And we'll also have the 2022 enrollment overview for everyone. So we'll give everyone all that information that we're talking about now. We'll see how everything looks in the AV calculator and with mental health parity. Then in March, we also have two meetings scheduled, March 8th and March 30th, depending on what we need to do, depending on where we are with the plan designs and any recommendations the committee wants to make. That gives us a few meetings to go over everything. And the plan is to make that proposal to the board for the April board meeting so that the board can then pass the plan certification requirements for 2023. So I think Julie and Brad, you all have your notes for the various items on the plans, correct? The different items that the committee would like you to look up for the plans.
Yep.
And I know
Yes, we do.
Yep, the carriers will be running everything through their own data and their own calculation. And I know Jill mentioned also being interested in knowing how consumers are spending their healthcare dollars, what they're spending it on. So we'll look at that. And I think those are the items that we had for next steps. If anyone else, if I'm missing anything, please let us know.
I have one more question. This is
Sure.
Jill again. When we made the change to stick to one standard silver plan per carrier, and at that time we had 2 carriers, we saw that when that wasn't the case, that a lot of APTCs from the feds never made it to Connecticut. And after we made that change, they came in. And the way the Affordable Care Act is designed, counterintuitively, sometimes when a third carrier comes in, actually APTCs go down. And we were able to make some of those, we were able to get some of that information of what happened. Of course, on top of that, we have the ARP, which has helped everybody. So it may be hard to tell what the impact of having basically a less expensive plan, which should be a good thing. You know, how did people's buying power get affected? And I just don't know, with so many things happening at once because of ARP at the same time as that happening, whether you can really tell. You know, because maybe it hurt some people a little bit, but then the ARP helped them, and so it was sort of a wash. I don't know if there's any way to have any kind of analysis of people's affordability situation.
Yeah, maybe on that end, maybe Weekly can model as if there is no carriers coming in and what is the subsidies would be or the net premiums would be, and then do it with the third carriers there. One thing that we did not, when we set the rule, I don't think we discussed about the definition of one standard plan per carriers, because that, if we stick with that definitions, by having 2 different legal entity in there is allowed. So I think we may want to discuss about the definitions of one standard plan per carriers, or is it per legal entity?
Mm.
I mean, the 2 Connecticut Benefits Inc. and Connecticut Insurance Company Inc. are separate carrier entities. You know, so anyone offering on the exchange has to comply with the standard plan offering requirements.
Yeah, so like for example, under Anthem, we probably have many legal entity there. On our interpretation, to be frank, we was thinking about that when we define per carriers, we are interpreting that Anthem, regardless of how many legal entity that we have, we only allowed to offer one standard silver plan. That's how our interpretations. And keep in mind that when we're thinking about the rule that we set here, is basically trying to maximize the premium subsidies opportunity.
Exactly. Yeah, exactly. Oops, someone's breaking up.
Sorry, yeah, Grant, you're breaking up a little bit, or a lot.
What, while Grant's trying to come alive again, I mean, that change to silver, one standard plan, two carriers was done for a reason, and it did have a good, it had an impact of bringing in a lot more APTCs and helping people with their buying power. And so whether that's for this committee to decide, like what is the definition of carrier, or whether that's a board decision, I think that we should be seriously looking at that. And then, obviously if United wants to come back in, or Aetna wants to come back in, there's nothing, that's allowed.
Right. We could, and obviously there are some people who, who feel that more competition is better and would like more carriers to be offering on the exchange.
Right.
Yeah, there is no difference between Connecticut and United and Connecticut Benefits and Connecticut Insurance Company. They're all separate legal entities. They share a common holding company view, but they're all separate companies. They're all separate legal entities. They're regulated separately,
But
and the
I think,
rules apply to each of them separately.
but you have the ability
Neil,
to look at,
which one do you represent, Neil?
yeah.
I
They
actually,
have the ability to talk to each other and set their prices, knowing what each other's prices are. I mean, it just, on the surface, it doesn't look quite kosher, according to the rules that we established, and there may be.
see, and that's where I object. We followed every rule that you established, so don't accuse us of not following the rules.
Right, so I think what we're talking.
Everything we did was upfront, above board,
Maybe we need to
and
change the
within the
rules.
rules.
That's what we're talking about, is maybe we need to clarify the rules.
What Neil said is 100% true. I agree with Neil. They're following. the
I
rules.
understand that, but I think what Tu said and what I'm saying is that maybe we need to clarify the rules. And so it would be helpful to understand the impact, if that's possible, on APTCs and, consumer affordability. Did Grant come back?
Ultimately, this would be a board, the committee obviously makes recommendations to the board, that the board is the ultimate body, that passes these requirements, so that's certainly something.
Is there a way to figure out the impact? I mean, is that, I guess, how would we do that?
I'd have to, talk to Wakely and talk to Rob Lundo and see if there's modeling we could do. But to someone else's point, or Neil's point, the market is open. It's not a limited market to two carriers. The market is open, to other carriers offering plans.
And I agree with that.
I'm not disputing that. I'm just curious. So,
Right. We can talk to Rob Lundo and talk to Wakely and see if there's modeling we could run.
I remember last time Rob was at least able to come up with, like, it was a net, it was just a big number.
Yeah.
Like, I don't know how much beneath that he could, but there was definitely a number he was able to come up with that had to do with when we changed our policy for limiting the number of standard plans.
Yeah, the modeling can definitely be done. I remember the same things, that the impacts of having one standard plan have a significant impact. I think the key here is making sure that whatever the committee recommend and clearly define what it is. So making sure that people interpreting the same way. I think that is the key. And then I agree with the point about if a new carrier is coming in and they have to set price, they don't have a connection between like the silver plan on how to price, because they have to do it independently.
I have a quick question. This is Paul. I'm trying to understand the potential end result. Are people suggesting that if the numbers turn out a certain way, that you can have two Connecticut companies on the exchange, but only one can offer a standard plan? Or are you saying only one Connecticut company can be on the exchange? What are we trying to get at here? What could be the potential end result?
I think right now we're just trying to understand the impact. But I think we also want to operate an exchange that is doing best by consumers and also has fair competition. So I'm not really sure what the answer is, but I think we just want to understand, this is a change that we ought to understand the impact.
Yeah, I guess I'm not arguing about the potential, the impact that this would have, having three companies offering a standard plan. I just don't know if the numbers tell us that without one of the Connecticut companies, we would get more APTC from the feds. What is that going to do? Are you going to kick one of the Connecticut companies off the exchange? That's the I guess that's the question that I would have is if the numbers turn out a certain way that indicates that if it's just Anthem and one of the Connecticut companies, and that would generate larger APTC for 2023, where are we going with this? Are we going to kick one of them off, or are we going to, I don't know how you have two Connecticut companies on the exchange and tell them that only one of them can have a standard plan, and you get to pick the one that has the standard plan after you see the rates to maximize your APTC. That gets a little that's I would think that that's a little difficult. And
Yeah.
I also suggest that you potentially have the same issue with a company like United that has Oxford companies as well. Most of these companies, aside from Anthem, because Anthem has HMOs as a line of business, most of the other carriers in the state have HMOs and indemnity companies. So this is setting precedent moving forward as to what could potentially happen. I'm not suggesting one way or another. I'm just suggesting that there's a lot here to consider by looking at this information and then attempting to use it to do something to rectify it or adjust it, so to speak, into the future, because most other carriers have separate companies as well. So that's all. I think the exercise of understanding what happens is fine. I'm not arguing that point at all, Jill. I think that certainly could be useful. I just don't know. I just would watch out as to what you do with that information moving forward. That's all.
Yeah.
Jill, were you talking about a state like California or Massachusetts maybe that had 6 or more plans, 6 or more carriers? Where did
I
you
don't know
hear
who's
about?
someone's got is trying to work and have kids and monitor kids at the same time. I just, well, I think we're all agreed it would be good to have the data, and then the implications of Paul. I appreciate what you're saying, that it's a wider decision than just about APTCs, but understanding how it works, where one company can basically talk to itself between its divisions so that they end up being the lowest cost plan and the benchmark plan. Like, is that the way we want to operate a fair marketplace? I just have a question about that. I think it's,
it's understandable, Jill. The only thing I can tell you is that the rate filings are separate and independent for each of the companies. And Connecticut Insurance Company's base rate is developed on Connecticut Insurance Company's experience, while CBI's base rate is based upon CBI experience. There is no commingling of experience. They're treated independently from each other, and all the assumptions are analyzed actuarially. We don't allow for shadow pricing, which I think would come into play, Jill, to your point, if they're going to play one off the other. But no, they have to support their rates and their assumptions. And there's other things that go into it, right? The risk adjustment values and whether there's a payment in or a payment out. So I just, that was the other point of clarification I wanted to make, is they're completely independent and they have separate experience data per each company. So for whatever that's worth, that's how it's reviewed anyways.
And
Also, Paul, my understanding, Paul, is that we don't have any authority to stop this from happening. Is that accurate, Susan, Paul?
I don't know how you could tell a company that they can't participate on the exchange.
Right.
I think Jill's point is that the real question is if you participate on the exchange, could you require only one standard plan from the Connecticut companies? I don't think you could deny a company from participating on the exchange as long as they meet all of your requirements, James, that are in the documents when you do your QHP request.
Okay.
Right. And I will point out that in other states, there are multiple separate carrier entities from, the same parent that participate in other exchanges as well.
And if that is the way that we want to go, and then I think we may want to clearly define that it's not per carrier. What does it mean? Is this per legal entity, or is this, so all the carriers, if they consider to have a second legal entity, they would have an options to do that?
Any entity that could meet the certification requirements, between SID and Access Health could offer plans on the exchange.
Right, and any carrier, and look at the list of carriers in the CMS annual report on risk adjustment. There's multiple Connecticut entries. There's multiple United. There's Golden Rule. There's Oxford. All that share the United umbrella. Aetna, Anthem, all have multiple carriers in there, and each and any one of those could submit in an application as a QHP. And Paul, you put it very well in what you said. I would take it one step further. When we were approached last June about it was either May or June, I forget, about the participating in the covered Connecticut program, that was not a Connecticut decision, right? Each of the two carriers had to participate in that program. So, we don't get off by just saying Connecticut is part of it because they're using the CBI license. The Chi-Chi license also has to comply because that's a rule of engagement.
Right, and any consumer enrolling through the exchange who's eligible for covered Connecticut could choose any plan by any of the carriers offered.
Correct.
Yeah, that's correct. Susan and Neil, with regard to covered Connecticut.
Grant, this is Ted. Could I make a quick point?
Sure. Oh, yeah.
Wonder, would it make sense for us to see a comparison with some other states and going back to the number of plans that are allowed for each carrier? Could we perhaps benefit from comparing with other states that are either particularly high or low performers or otherwise particularly interesting in terms of their approach to, and I know there's radically different approaches out there amongst the states. I wonder if maybe comparison to New Mexico or some other states might help this board understand, to make sure that we're looking with a fresh eye every year on our philosophy and our approach to this, which I know can vary widely between different states.
Julie, are you still on the call? Is that something Wakely could do?
Yeah, we can take a look at like specific
state. Yeah.
I mean, it
What
might
is
be
their
good-
approach?
Yeah, some state-based exchanges. I'm not sure comparing Connecticut to California is good. Is that useful? But
Yeah.
I don't know, like
Well,
what
I
other
mean,
way.
I was using that as the extreme. Don't they have like
Yeah,
regional plans and they have like, 10 or
Yeah.
15 plans across the state? I kind of wonder how they approach it because their plans aren't offered throughout the entire state. They cover a county or they cover, a region.
Correct.
Mhm.
Correct. In some
so-
other states, they have plans just in certain counties.
Yeah.
We have, we require that
Do
plans
they
are
do
offered
they
throughout.
adhere to the second lowest plan, or is it the second lowest plan within the catchment area? I mean, how do they handle it? Massachusetts
It-
has many plans, 6 plans or something, and they probably face it.
Yeah, so
It'll
it is
differ in each county. Sorry, Julie, because it'll be, I mean, just like in Connecticut, the second lowest cost silver might not be the same in Hartford as in Litchfield or for someone's age
Okay.
group. So
Oh,
that will
okay, so
vary.
it's 20.
Yeah, it'll
Okay.
vary by
That helps.
rating area, Grant. In Connecticut, the rating areas happen to be the 8 counties, but in general terms, the larger states are only allowed, unless they've petitioned, up to 7 rating areas. We had identified that we had natural rating areas of 8 counties in Connecticut and petitioned and got that exception made by the feds. So it's not to say that other states haven't gotten that, but it's not always by county. One other thing I wanted to mention around this discussion is in the benefit payment and parameter notice for 2023, there is a potential requirement that each carrier participating on any state's exchanges for the federal exchange or a federally facilitated exchange or an exchange that uses the federal facility would be required to offer a standard plan. Not to say that it would be the only plan that would be offered as we have for silver, but they are contemplating that within the benefit payment and parameter that they require. And I think it gets to Jill's point about apples to apples comparison. Very similar to what the feds did with Medicare supplement standardized plans. Prior to a certain point in time, they were non-standardized plans, and it was difficult for people to compare from carrier to carrier. So now MedSup has standardized plans. They've had it for umpteen years. So they're looking to do that with the exchange plans as well. So I think that's appropriate to have standardized plans, and they're moving in that direction anyways.
Yes, this is exactly how I.
If I could just jump in, just to speak to the group, but also to Julie, what I'm thinking about with cross-state comparisons is right now we have 13 available plans, right? There's the 4 standardized and there's the 9 that are non-standard. For regardless of how many carriers are in a particular, other state, I'd be interested in knowing how many of them have only 4 or more standardized plans. Are we an outlier in that regard, or are we in line with some of the states? And how many states have non-standard plans that total 9 or more? If you see what I'm saying, so how much standardization and how much non-standard plans are offered in different states might be important for us to put into perspective what we're trying to accomplish here in Connecticut.
Okay, so the scope is more about how many standardized plans are offered, you know, as far as like the amount of choice.
You know, I
That-
think
that-
Connecticut has been a leader in setting standard plans. Like we've definitely been a leader. So I don't think we're going to learn a lot from that part of it, but it's like the amount of choice definitely, which is I brought up earlier, you know, in each tier, and then how many states have this situation, which I'm sure many do, where subsidiaries of the same company are in there, are competing, in what that looks like. I think there's probably a wide variety of things that are going on, and whether it's worth looking at only at state-based exchanges, and should we only look at states that are quote unquote similar to Connecticut, which no two states are alike. So I think it is a little bit hard to figure out how to make this like a doable scope.
Mhm.
And
Yeah.
also to follow up on what maybe Ted was just saying, or Julie or Jill, in the beginning, we were one of the few states doing standard plans. And as the years have progressed, we know from our NASHP group that we participate in that many other states are moving in that direction. So they are starting to adopt standard, you know, understand the benefits of using standard plan design and creating standard plans. And to Paul's point in the notice of benefit and payment parameters, they've got items in there on requiring the FFM states perhaps to start having standard plans, and the display of how the standard versus non-standard plans would show. And also, I think even the plan mix between the number of offerings. So it sounds like other states that haven't done things the way we have are kind of moving in that direction as well.
Yeah, in terms of Jill's very valid concern about the paralysis of too much choice, you know, is 4 standardized plans the right number? Do it need to be higher or lower? Non-standard plans, we have 9. Is that the right number? Does it need to be higher or lower, or what information can we derive from other states? And I hear you're saying people moving towards standard plans, and that's good to know.
It's about the non-standard plans, because we're not going to change our minds about one standard plan per tier. Like that's a good thing. Otherwise, when you have 2, which, you know, we did that already, and I don't want to go. I personally, and I think other committee members would agree, like a standard plan is a standard plan, 1 per tier. But it's about the non-standard plans, which we had already talked about, how much, you know, what level of choice. And I realize it becomes a multiplier depending on how many carriers there are to begin with. But it feels like maybe now that we have 3, that, you know, I'm wondering if we're starting to bump up against the fact that those extra non-standard, having 3 possible non-standard plans in some of these tiers, maybe it's pushing the envelope. Are they sufficiently enough different? That's why seeing the AV for those will be helpful. For what we offered last year will be helpful to see, at least by AV, how different they are from each other, how they compare. Some may have lower AVs than our silver plan, because our silver plan, you know, is a pretty rich silver plan. But then, so I think it's, and then a separate issue is how states are handling this multiple subsidiaries of the same carrier, which I have a feeling there's a fair amount of it going on. And if anyone's ever had any concerns about it.
And I would also just note one other item to think about if you're, you know, thinking about looking at the plan mix, to just remember that people are enrolled in all of these plans. So if you were to make a change, you're going to have disruption for consumers. You know, people, if they have a plan that they like to renew and stay in that plan, you know, year over year. So then you run the risk of, you know, possible discontinuing a plan that people may like.
Yeah, that's why it'll be good to have the distribution.
Right. We'll get that information at the next meeting. So we'll see how it falls.
Okay. Is that, Susan, you,
Yep, we are at the end of our
you at the
presentation.
end,
So
want
as
to do
we,
next steps or?
yep, well, I think we did the next steps, Julie.
Oh.
Julie's got the different information, and now we had a great discussion. Some other items that we want to look at for the next meeting or as soon as we can get the information. And as we've mentioned, to note, some of the questions that have come up, there's a lot of really helpful information also in the appendix for this deck. So if there's, you might have some other things you want to look at, or you might just want to scroll through the deck to see, what might be in there that you might be interested in looking at. So I think we're good, Brad, on our end.
All right. Okay. Well, thank you. Thank you. Great meeting. Thanks everybody for attending. I'd like to hear a motion to adjourn from some member.
So moved, Ted.
Ted, seconded.
Second, Jill.
Okay. Let's have a roll call on that.
Frank Ritter,
Yes.
Peter Doolittle,
Aye.
Mark Schaefer,
Yep.
Matthew Brockman, Tune Cohen,
Yes.
Neil Kelsey,
Yes.
Ellen Skinner, Jill Zorn,
Yes.
and Manisha Jutani. Thank you.
I think she had to make it.
Okay.
she
Well,
had
thank
to
you very
step
much for
away.
coming. See you soon.
Thanks, everyone.
Thanks a
Thank
lot.
you, everybody.
Bye now.
Bye-bye.
Bye.
Thank you, everyone.